Okay, I would like to welcome our first speaker, Dr. Moon. Dr. Kyoung-yong Moon, he's an OBGYN doctor specialized in fertility, who has worked for years in one of the largest IVF centers of South Korea, um, Maria Fertility Hospital in Seoul. Today, he will share with us a few reasons why he was one of the first physicians in Korea to recommend ERA for patients suffering with a history of recurrent implantation failure. Dr. Moon, he graduated from Seoul National University, and he was also a physician from 2014 to 2019 in Maria Fertility Hospital at Seoul and Busan. And from last year, 2020, till now, he is a representative of the IORA Fertility Clinic. Let's welcome Dr. Moon.
Hello, ladies and gentlemen. Nice to meet you online. I'm Kyoung-yong Moon, and I am a medical doctor from IORA Fertility Clinic in Suwon, Korea. And thank you for Igenomix APAC team to join me here in the second APAC Symposium. Today, my symposium subject is Efficacy of ERA with my patient's case review. Here are contents of my presentation. Brief introduction of ERA. I will skip the detail of ERA test because other speakers today will cover ERA subject too. And then how does ERA test work? And the efficacy of ERA. So far, the clinical data in Korea is not so many. So today I will cover my own case series. Implantation consists of highly complex and multifactorial process. It needs important communication between embryo and endometrium. An ERA test is aimed to find the displaced window of implantation among RIF patients. The displacement of window of implantation leads to embryo transfer into a non-receptive endometrium. During omics era, Igenomix in Spain, Valencia, developed 238 endometrial genetic markers with microarray method. Now, Igenomix is commercializing NGS technology for 236 gene expression profiles by RNA sequencing. And the ERA identifies whether the endometrium is receptive phase or non-receptive phase, such as pre-receptive or post-receptive. As you already know, basically, in artificial frozen embryo transfer cycle, estrogen is first applied for endometrium's thickness. Then when endometrium becomes thick enough, progesterone is started. Usually, clinicians consider the window of implantation to open 5 days after progesterone administration, so we transfer the blastocysts at that time. In ERA cycle, the endometrium biopsy is performed at that time instead of embryo transfer. When ERA comes out, when ERA result comes out, we can find out whether the patient's window of implantation is displaced or not. In case of patient A, her window of implantation is not displaced. So the ERA results in the receptive endometrium. Patient B has delayed profile as pre-receptive, which means window of implantation has not opened yet in biopsy time. Patient C has advanced profile as post-receptive, which means window of implantation has already closed in biopsy time. You can see the overall ERA result statistics. About 69% of receptive and 31% of non-receptive. Among non-receptive, mostly of pre-receptive, and post-receptive is found only in about 13% among non-receptive. ERA results are interpreted in 12-hour increments. If the ERA result is early receptive, it is judged that window of implantation is about 12 hours later than the biopsy time. Therefore, the blastocyst at the time of implantation is then transplanted. In the case of late receptive, it is judged as window of implantation about 12 hours earlier than the biopsy time. Pre-receptive and post-receptive means when there is a difference of about 24 hours from the biopsy period. If it's pre-receptive and it makes a difference more than 1 day, a retest is required. In the case of post-receptive, even if the difference was only 24 hours, a re-examination was required. Now you see the globally 90,000 ERA result accumulated until 2019 year. About 70% from receptive group and 24% from 1 day pre-receptive result falls into the first embryo transfer time provided, and then about 6% was falling to the second biopsy command group. From the APAC region statistics in the right pie chart and table until last year June, you can see about 35% performed the second biopsy, and the result shown more than 99% have ET time recommended result. In Korea, we have 320 ERA cases until this January for 2 years. Then the data is showing similar statistics as global. 43% receptive and 13% early, 10% late receptive, and 21% pre-receptive, and 8% post-receptive. Remaining 6% has no result due to limitation of the input sample or experiment. Also, Korea have clinical data from 215 responded patients. These statistics showed mostly 3 to 6 times implantation failure patient group was applied ERA test, and implantation failure patients with over 7 times group have more than 50% non-receptive result. We can see less than 50% receptive in patients with over 7 attempts of previous failure. So I analyzed more with break down those two groups and analyzed statistically more in detail. Total 215 cases excluding non-responded number implant failure and second biopsied. When compared to 128 cases between 1 to 6 times of implant failure, over 7 times implantation failure women group has less receptive ERA result compared to this group. You can see 31 versus 46.9%. And that showed statistically significant. The p-value was 0.02. Also, from those group, the wide receptive result extended to here. The receptive plus early receptive and late receptive, the proportion was about 51% compared to about 67%. And the difference was also significantly different. The p-value was 0.01. In conclusion, women with a higher number of implantation failures had a lower rate of receptive. So I think it implies the reliability of the ERA test. From this slide, I will share my patient's case review who received ERA test. I treated total 60 ERA cases until this January, and here are 3 cases detailed first. The first patient was a 30-year-old female and had a relatively good ovarian reserve with an AMH of 2.90 nanogram per milliliter. With both tubal obstruction and the cause of infertility was a tubal factor. In the first fresh cycle in August 2016, 17 eggs were retrieved and 2 embryos were transferred, but there was no pregnancy. She had frozen embryos at the time, so she did a frozen embryo transfer once more, but she was not pregnant either. She underwent 1 more fresh cycle and another 1 more frozen embryo transfer, but she has not continued to become pregnant, and she has been transferred to our hospital. In January 2018, 19 eggs were collected, and she was not pregnant even though she had implanted a pretty decent embryo at 8-cell grade 2 embryos on the 3rd day. In May, extended culture was carried out to cultivate blastocyst. Even though blastocyst was transplanted, pregnancy did not occur. In August, when blastocyst was transplanted as a frozen embryo, pregnancy did not occur. Eventually, she had an ERA test, and about 121 hours after the intramuscular injection of progesterone, her endometrium was in the early receptive phase. So her implantation window was 133 hours after the onset of progesterone. According to the result, when endometrium became thick enough after administration of 4 tablets of Proginova, that means about 8 milligram, progesterone called Shigest was given at a dose of 100 milligram per day, and after 133 hours later, blastocyst was implanted and she became pregnant, but the pregnancy became missed abortion. This is the second patient. She was a 40 years old woman and who had very poor ovarian reserves. She ran 6 cycles, 6 fresh cycles and 1 frozen cycle from July to 2016 to October 2017, but all failed. She came to our hospital in August 2018, and even though she ovulated, only 1 egg came out, but we succeeded in culturing the blastocyst and transplanted it, but she failed to conceive again. She subsequently underwent mild stimulation several times, and she continued to fail her pregnancy. I did ERA test on her, and as a result, she was receptive. So she was more desperate that the window of implantation had not been displaced. Although the window of implantation is not displaced, the strategy was to implant the embryo at the implantation period into the endometrium with an open implantation window rather than a fresh transfer. We cultured blastocysts and implanted hatched blastocysts 120 hours after progesterone administration in a frozen embryo cycle, resulting in an ongoing pregnancy. This is the third case. She was a 41-year-old female, had a history of right salpingoforectomy, and a patient with left hydrosalpinx and tubal factor infertility. She came to our hospital with 2 fresh failures from external hospital, and after blastocyst transplantation, she became a chemical pregnancy. In December 2018, 6 blastocysts were successfully cultured and all cryopreservation was done. Left hydrosalpinx, which could interfere with pregnancy, was removed through surgical treatment. However, she was not pregnant even though she had a frozen embryo implant after surgery. I finally did an ERA test and her endometrium was still in the pre-receptive phase 120 hours after progesterone administration. Therefore, the remaining frozen embryos were implanted 6 days later after intramuscular injection of progesterone. That is 144 hours later, resulting in an ongoing pregnancy. In this way, I have organized all of the ERA tests that I have conducted. This is the list. This number is in the order of patients, and both patient ID and name have been sorted out, and now they are blinded for presentation. The date of biopsy of the endometrium and the date of obtaining the ERA result were also summarized. Results were generally obtained in 2 to 3 weeks, and recently, results can be obtained in almost 2 weeks. In this way, all ERA results are summarized. This number is the number of previous failed embryo transfer cycles. Some patients have failed 3 times, while others have failed very, very many times. This column is the denominator for the number of embryo transfers and the numerator for clinical pregnancy since the ERA result was obtained. Ages are also organized and vary widely. The first patient was a 37-year-old woman who had failed 3 times and was pre-receptive with ERA results. Therefore, when the blastocyst was implanted 144 hours after progesterone administration, once she became pregnant and became miscarriage. But in the second, she succeeded in ongoing pregnancy. In patient 3, 121 hours after progesterone administration, her endometrium came out post-receptive. So she was recommended to retest 97 hours after progesterone administration. But she lived in Canada, so she got this up to this and went back to Canada. In patients 4 and 5, the ages were 36 and 38 respectively, and the number of previous implant failures were 8 and 6, but both ERA results were receptive. Therefore, when blastocyst was transplanted 120 hours after progesterone administration, the first was chemical pregnancy, but the second one all succeed in ongoing pregnancy. Patient 7 was my first case presentation patient. Patients 9 and 10 also succeed in pregnancy after ERA, despite the fact that they failed 6 and 8 times, respectively. And patient 10 was case 2 presentation patient. In the case of patient 8, she was 32 years old, but she had endometriosis and had poor ovarian reserve and failed 11 times. According to the result of ERA, when blastocyst was implanted 132 hours later, there was never any beta-HCG value before that, but it was the first time that a positive beta-HCG result was obtained, even in a biochemical pregnancy. Currently, she has collected blastocysts and is waiting for a transplant after surgery for adenomyosis. Patient 14 is the third case presentation. In addition, these patients succeed in ongoing pregnancy when transplanted according to the result of ERA. In the case of patient 28, when I did an ERA test on this patient 120 hours after progesterone administration, The result was post-receptive. So I was recommended to retest 96 hours after progesterone administration. However, after that, I moved the hospital to my current office. So then when the doctor in charge re-examined 96 hours after the ER recommendation, 96 hours after progesterone administration was correct. So the blastocyst was implanted at that time. As a result, I was told that she became pregnant but then miscarried. Anyway, it was successful in clinical pregnancy. Starting from patient number 32, these are the patients I have treated at the IORA Fertility Clinic, where I am currently working. Patient number 32 was 44 years old, pretty old, and after 8 failures, she succeeded in pregnancy after ERA. However, this was an unfortunate case of termination due to a complex deformity found on level 2 ultrasonography at 22 weeks. Also, in the current IORA fertility clinic, for even women who have failed implantation very many times, I performed ERA on them and obtained good results when implanted as the result. In the case of patient 35, she had failed 9 times, but as a result of ERA and personalized transfer, she succeeded in ongoing pregnancy. Patient 40 also failed 9 times, but she succeeded in pregnancy after ERA, but she has aborted and is preparing for the next transplant. In patients 49 and 51, their first attempt ended with a chemical pregnancy and a miscarriage, but they made a second attempt a while ago and are currently monitoring their pregnancy. In case of patient 54, the result was insufficient RNA in the first ERA. She has a history of myomectomy due to huge myoma, and the result seems to have come out because the endometrium on the fundus side was not sufficiently biopsied due to the resulting deformity. In the second biopsy, when the biopsy catheter was pushed a little more, the result of early receptive was obtained. Patients after this had undergone an ERA test and are waiting for the result of pregnancy. Now I will go over my data statistics. So far, I collected total 62 ERA cases, and then 35.5% was in receptive result. The proportions of early receptive, late receptive, pre-receptive, and post-receptive came out like this. The target group for which I performed the ERA test was 28 to 47 years old, and the average age was 38.7 years. The number of previous implantation failures was relatively high, ranging from 3 to 22, an average of 7.4. Nevertheless, the overall clinical pregnancy was 50%, and the ongoing pregnancy rate was encouraging at 35.35%. Interestingly, there was no significant difference in pregnancy rate in the receptive, early receptive, and pre-receptive groups. Isn't it very interesting? Finally, after all my case analysis, this discussion topic came to my mind and self-questioned why. First, why is the pregnancy rate not inferior in the receptive group, though their window of implantation is not displaced? My first answer is uncertainty of embryo development speed. Sometimes in fresh IVF, blastocysts can form at various times, such as 4.5, 5.5, or 6 days, not exactly 5 days later. So they are not perfectly synchronized with window of implantation. Therefore, even if the result of ERA is receptive, the pregnancy rate is higher than before when hatching or hatched embryos capable of now that are intended to be implanted in the receptive endometrium, which we know are transplanted. The other reason can find from exogenous progesterone method, such effectiveness intramuscular or vaginal progesterone. For some women, vaginal progesterone can be insufficient. My second question, is ERA also necessary for women with history of positive pregnancy tests? And my answer is yes, because as you can see from my patient's case, their previous implantation success were lucky from synchronization. Even if the window of implantation is displaced, if it is possible if the embryo development rate is also displaced at the same speed with window of implantation. ERA might help them to find better timing for well-developed blastocyst implantation. Third, timing of thawing blastocyst is quite questioned matter to me, and I applied ready to hatching embryos on embryo transfer. In my experience, ERA ET time is quite matching with hatching or hatched conditioned blastocyst. So, in case of less developed blastocyst, that is just before hatching, I extended 1 day more culture after thawing. Lastly, unfortunately for women who have poor embryo only, ERA might not work for embryo implantation, even if it indicates window implantation. Thank you for listening.
Thank you, Dr. Moon. I think it's a very, very, very good and interesting presentation. We have quite a few questions, but because of the time, we will just ask you one question out of the questions that were posed by the audience. Okay. Did you notice that any trend in your study regarding the patients with advanced maternal age? The age, is it age related to WOI? Do you see any trend that the advanced maternal age may have a higher rate of a displaced WOI? Can you answer this question, please?
I did not examine correctly, but I think the age is age does not affect the window of implanted displacement. I think age is independent from the displacement of window of implantation. There's no relationship, I think.
Okay, thank you very much, Dr. Moon, and we will move on to the next speaker. For the other questions, we will send the questions to you by email, and then
Thank you.
after you answer us, we will provide that. Thank you very much.
Thank you.
Thank you.
Thank you.